You better know how Medicare works. You better know what repricing on a Medicare level means. You better know the core differential between everything from 100 to 150 to 200. You better know those numbers like the back of your hand.
We're going to be talking about reference-based pricing today. So, what is reference-based pricing? What are the different models out there? What makes sense? What doesn't make sense? What are the ins and outs, the good, the bad, and the ugly? And, you know, we like to work with experts here. So, I wanted to bring on a special guest, special expert that's been doing this for a very, very long time in reference-based pricing. And that is none other than Robyn Jacobson, CEO of Intrust. Robyn, welcome to the show.
Thank you, John.
All right. So, sorry we had some technical difficulties, guys, but we are here. We make it work. Robyn's shooting in from a cell phone, okay? When all else fails, go back to the cell phone. It's crazy. You got all this computer, all these cameras, and yet the cell phone always seems to work when everything else fails. So I can hear you good. Let's get into it. I want to talk about, just give a brief overview of what RBP is and when and why did it come around?
So first off, John, I just want to say thank you for coming on or letting me come on your show today. But in the simplest terms, this is when an employer establishes a price, a maximum price that they're willing to pay on any covered medical service. But if you've seen one reference-based plan and how it's priced, that's what you've seen. You've seen one, because there's every flavor in the marketplace today. So that's what it does. Sets a maximum price, doesn't use a network, and the claims are adjudicated according to whatever that maximum allowable amount that is defined in the plan.
And so, when did reference-based pricing come to the market and start to come around, and why did it come around?
Well, reference-based pricing really was a natural byproduct of the frustration of not having a free market in medical care today. It's only part of our economy, as your audience knows, where we do not have the price in advance of services. And yet we're forced into this medical liability environment, and the pressure built, and finally it had to burst. So we had the HMOs in the 80s, and we had the PPOs in the 90s into 2000, 2010. But by 2005, prices had escalated to a point where cost shifting was going from the employer back over to the patient or to the member or to the participant, and enough was enough. And the market decided, hey, let's start establishing what that price is that's reasonable in advance. So we actually started in 2007 establishing for certain covered medical procedures what that reimbursement would be, working collaboratively with our employer clients who are willing to do it.
So you started in 2007, and you went from doing out-of-network reimbursement, you moved over to in-network reimbursement, and what just happened? Employers had enough. They saw what you're doing from an out-of-network standpoint and said, "What we want. How do we do it on all of our claims?"
Right. I mean, it's pretty straightforward. And when employers started getting educated about healthcare, the pricing of healthcare, the pricing variation of healthcare, where you could go down the street and get a colonoscopy for $8,000, or you could go down and get an all cash price and negotiate a price directly and get a colonoscopy for $1,000. All of a sudden, the employer's light bulb went off, and they said, enough with this. Let's stabilize this pricing. Let's not have pricing discrimination. Let's stop this crazy rat race of outlandish pricing, and let's bring in some reasonableness, some fairness back into the marketplace.
And so, for us out in New Jersey here, obviously people think in the East Coast that we're ahead of everybody, but in healthcare, as I travel the country, I find that we are far behind anybody, especially New Jersey, which really hasn't had a ton of RBP here. You guys are in Texas. You guys start this in 2007. Talk to me about what you've learned along the way, the good, the bad, the ugly, because this is fairly newer concept, only a couple years old here in New Jersey, and a lot of consultants and brokers. It's becoming bigger over the last, I'd say, 3 to 5 years. What have you learned over that 12 years through the reference-based pricing model?
Boy, there are a lot of lessons that we've learned. And I think the first one is how important it is to educate your membership, your participants. Certainly, it starts in the brokers educating the employers about this price disparity that we're talking about. We don't have transparency in healthcare, so we're trying to bring transparency in healthcare by educating the members about it. And if you don't get them engaged, then if we don't make them better consumers, we're never going to break this paradigm. We'll jump immediately into a national healthcare system, which we think would be a shame after we've never given free market in healthcare even a chance. So the first lesson is literacy. Let's make our employers literate, but more importantly, let's bring health literacy back into the members. Let's put them back into the control place. The second thing that we learned in reference-based pricing is you need to be adaptive to the employer's needs. Reference-based pricing is not one size fits all. You've got to understand that employer, understand the members, their employees, and what their economic boundaries are. So that's the second component. And I think the third and foremost is that you've got to be reasonable with the providers today. If you try to reimburse a provider, a hospital, 120%, let's say, of Medicare, and typically these reference-based plans are based on a percentage above Medicare. Why? Because 55% of America has their claims paid on one pledge. Well, at least people understand. At least the grandmothers understand. And that's Medicare. But if you reimburse a hospital 120% of Medicare, any good actuary is going to tell you that the general expense for a hospital to break even is going to be at 122% of Medicare. So if you're only paying them 120, what do you think is going to happen? So literacy is so important. I can't really underscore the importance of health literacy in the process.
So you're saying is basically, listen, if you're going to try to jam down the throat a provider or a hospital, well, I should say provider hospital systems, 122%, that's their break-even point. And yeah, they're not going to want to accept it in most cases. So, my next question would be is you've already brought it up, is these different models, right? There's multiple models, and we're going to get into your proactive RBP model that you guys developed over the last 12 years. Is what are your thoughts about the other models? The most popular one, I would say, and most people know about, is a percentage of gross bill charge. They're charging 10, 11, 12% of gross bill charges to reimburse a percentage of Medicare, whether it be 150, 120, okay, and we'll protect you from balance billing. You don't have to worry about balance billing. If they come after you, we'll handle it. If they try to sue you, we'll handle it. What are your thoughts on the other models that are out there, and what have you learned against them?
Well, I think it starts with the basic is, why are there other models out there? We started paying a Medicare-based fee schedule off of a Medicare-based fee schedule in 2007. We don't go to a vendor to do that. We adjudicate those claims on that fee schedule using our proprietary in-house claim adjudication software. If you don't have the capacity to do that, then you would be forced to use an outside vendor. There's no doubt Medicare is complicated. Absolutely, no doubt. But when you use an outside vendor and you pay less than what is reasonable, and we can all debate what is reasonable out there. But I think we can all agree that 120% of Medicare is probably not going to be reasonable if the break-even point for a hospital is at 122% of Medicare. So, if you're not paying them adequately, that is going to be pushback. There could be providers that will not see the patients. You're going to have an HR problem that's just untenable. And now you get to really pay royally for that by adding a percentage of whatever the fees are on top of that. So from our perspective, we think that it's time that the market experience a fair reimbursement strategy, understand fair today, and the difference between 120% and 150 or 170% for a hospital is not as great as you think. These are not natural multipliers. The difficulty is that the networks were yielding 3, 4, 500%. And frankly, we've seen many claims come in at 10 times Medicare. And at that egregious billing process, you have to go to something. But if you go from a PPO at that level for commercial, and you've got hospital systems that are seeing patients that are Medicare or Medicaid, which is typically 80% of that Medicare amount, when you see providers in that kind of stress environment, they have no choice but to protect themselves, which means it's not going to yield a positive result for that employer.
I think what I'm hearing around the market right now from brokers that have been doing it for a couple of years now is that I think the hospital systems are catching up, and where the story was great of 150, 120, they're going to take it and we'll protect you, or we'll sue them in court and they ain't going to win, or they're not going to want to take us to court, is, that they're having challenges now, and the hospital systems are telling them, or the providers are telling them, no, listen, you can't come here anymore. If you're gonna try to pay that, you can't even come here or schedule anything more, when they're checking what networks in advance that they're utilizing, or their reimbursement level. And I've always came from the standpoint of listen, I want to do what's right for my client. I want to get them the most competitively priced plan and payment for claims. But at the end of the day, I'm running a business here. I don't need to lose sleep overnight. I got enough problems in my life. Let me tell you, Robyn, that's another Facebook Live. But I don't need to deal with the headaches of, listen, we're gonna balance bill you, but they can't pay you. They're gonna have to accept what we pay. But I talk to brokers every day now, and it's like they've got bills and claims outstanding for 6+ months. And I think that's the side of the story that maybe you don't hear about from the market and the players that are doing that, because I've stayed away from RBP in my market for the most case here. But I think what's happening is they're catching up. Would you agree?
Oh, they're definitely catching up. I think what the critical component there, John, is you've got to use your plan design in a fashion that maximizes not only the cost savings for the plan, but the cost savings and minimize the out-of-pocket for the member.
Go into the proactive model of how we go from, instead of the jamming it down to a percentage of Medicare, and it's a after the fact model where it's go get your services and then we'll deal with it later type of model, versus what you guys created over the last 12 years.
Well, what we found is we need a safe harbor. You need a place, a quality facility in the target market that will see your patients. And what we've done is that we've negotiated with these players, these hospital systems, 0 out of pocket if they are steered to their facility. So imagine if you're an employee today and you're on a PPO plan, and it's a high deductible plan because cost shifting's occurred, and you've got your max out of pocket up to $7,900 a year. It starts with your deductible, and that might be $3,000 or $4,000, might be 2 or 3 times per family. And you are in a situation where you just can't afford it anymore, but you were given the option now, and you said, okay, you can go to your PPO provider over here, but what if we just added a layer and through plan design, and we steered you to a hospital that wants to see you? That's a quality facility that agrees to not only a lower reimbursement on a percentage of Medicare, but also agrees that at no out-of-pocket expense to the member. So you could actually go to a facility when you needed it and not have that expense strapping your pocketbook. And I think that is the strategy hospitals like, because they now are in the collections business. These high deductible plans, that's what it's yielded for them. They want out of it. So how do you get them out of it? Well, let's steer them to the good ones. That's what we do.
So you've put these safe harbors in place. Talk to me about the process, because I've always been cautious to the process of, there's no network. Just go in with this and have your surgery, and we'll deal with it on the back end. And my thought is always, what if they deny it when it's a surgery that's scheduled in advance? Emergency is a different story, but if it's something scheduled in advance, talk to me about the process of how you've alleviated the pain for the employer, the member, and obviously the broker themselves, because we're the ones that are putting our clients into this. And at the end of the day, we're the ones that got to deal with the problems. And listen, these plans don't pay that much more than the other plans. So it's a lot of risk that we take on as a broker, advising this to our existing clients.
So the process is pretty straightforward. It starts with a good plan design, followed by good communication and education of the members. And it's followed with a reasonable reimbursement strategy, the ability to be able to go to a safe harbor. The safe harbors, these hospitals are sophisticated. They know their numbers. They know what their cost of care is. They know their payer mix. They know what their base Medicare rate is. They know what they need to be able to survive. And the hospitals, in that sophistication that they have, will easily be able to add terms if you do not have a professional in there that knows those terms. And that starts with a good lawyer. You have to have a lawyer that can go in and negotiate good terms, but all the terms, because it's not just about price. What are they going to do with the injectables? What are they going to do you, and how are they going to upcharge you on the medical devices? Remember, 85% of all services are scheduled today. You schedule a hip, a shoulder, a knee, etc. So those are the ones that you need to know in advance. Waiting for the post-service environment to be able to negotiate a claim is unfair. We believe in engaging and not only making that member smart, making the employer smart, but we believe in disclosing right up front to that hospital, to that physician, exactly what they're going to be reimbursed. So they know in advance. It is on their ID card. They know what they're going to be reimbursed. They have the choice right up front whether they want to see them or not. Knock, knock. We've never had any of our patients ever turned away.
So talk to me about that, the biggest elephant in the room, right? So, I think the other model and why I've even said, years ago is I'm not going to do the other model. I'm going to do this model because they protect me from balance billing. If they go to court, they're going to handle my legal fees. So that's why I'm paying so much on the fees to the vendor of gross bill charge, which is another conversation. But what happens in your model now if they balance bill the member? You're reimbursing them what, $170? You're deciding, hey, we look this specific provider up. We think that 170 is reasonable. They're going to accept 170, they're going to accept 150. What happens now if they decide, hey, we're going to balance bill the member?
Well, for 20 years, John, we've been negotiating claims, and we were doing advocacy and concierge work before it was popular to even use those names. We've got 12 nurses that do nothing but help us in that category. We've got advocacy and patient advocates in-house. We have benefit specialists. We have claim specialists. We've got social workers. We've got collection experts, all that are prepared and equipped and experienced to go out and negotiate on any balance bill that can come in. The key trick is be reasonable and fair in what your reimbursement is to mitigate any of that balance billing. And by the way, there's less than 1% balance billing across the board. So people talk about a fear that may or may not even be reality. We do not see a gross amount of balance billing. It just doesn't exist. Now, we have some solutions to that. One option would be employer can actually buy a like an indemnity product, buy a balance billing protection for their members. They could do that. Provides all that coverage and the legal care that they need. Another option is let's use our stop loss partners where we've got decades of experience with them, and let's work with them. So when you have a claim that comes in, that's an emergency room typically, and we need to negotiate on those emergency rooms, how are we going to do it? What percentage of Medicare would be reasonable? And you know what? We find that if you're reasonable with the providers, they're reasonable with you. So it has been a non-issue for us, John.
Well, I'm gonna push back a little bit here on you because I'm
right
on the other side. It's the emergency room claim. You pay them 170. They push back. Let's say you got to pay them more money. What can you go up to as far as payment? When that happens, is the employer on the hook? Is stop loss on the hook? Is my E&O on the hook? What happens in that situation? Because that's what's going through advisors' minds in that situation.
That's a great question. What we like to do is work with our stop loss partners, and we will actually build a protection component into special provisions on that policy, and we will which protects that employer from any additional expense out of the allowable amount or above the allowable amount. So let's say hypothetically, and the highest we've ever had to do this, by the way, is about 223% of Medicare. And if we had to negotiate, well, if the plan only allowed up to 170%, well, who's going to pay that difference? Well, you know what? You buy coverage for the employer for that very rare occurrence when it has to happen, but at least there's protection for the employer. So that's what you do. You buy protection, you talk about it up front, and you have people that are experienced, and you work with stop loss partners that understand it.
In certain situations, do they allow you to pay more and be reasonable to pay up to a certain dollar amount, knowing, I've had a conversation with stop loss carriers that say, we understand we're going to have, or other of the vendors that pay the 150 would say, well, we've got discretion with our stop loss carriers to pay more money to these vendors, to these hospital systems.
So, yeah, the stop loss carrier, if you work with good ones, and you do, John, by the way, you've really done an amazing job at solidifying those relationships and really bringing best practices to bear when it comes to the risk components. But when you work with good partners, you set the parameters up front. They know that when they're working with the right TPA partner, that they are going to have the cost containment strategies in place. They're going to rely on that TPA to exercise them. They know they're going to have, for example, bundled surgeries negotiated in advance, sources where we can go to get those. They might work with specific physicians in order to enable those fees to be, or those expenses to be mitigated. So there are lots of ways, but it all starts with really having that good relationship with that carrier.
And how important is that from a standpoint of when you're underwriting risk, underwriting the partner, the administrator, knowing, because I would have stop loss quotes a lot, and they would ask me, well, what TPA are you using? And how important is it to have the right administrators, because they understand the practices that you have versus reimbursement levels, what they've seen in the past, how you manage claims, how you negotiate claims?
Well, I would love to have a stop loss partner on here right now to answer that question. But in the old days, 30 years ago, carriers used to underwrite the TPA in their practices just as they would underwrite a group. Today, when we bring on a new carrier relationship, there's a whole process of due diligence that we go through, just like we did go through the due diligence, John, with your stop loss partners. And we walk through the supply chain of cost containment on the RX and medical side. We come to them with containment options that they may or may not have even thought of before. And the most important part is that we're executing them. We actually show up and do what we say we're going to do. And that the greatest evidence of that is having a low risk level with that particular carrier. They know what you're going to do, and they know your loss ratio is going to be a fair and reasonable loss ratio.
Well, I got to bring it up because you're talking about, you had mentioned utilizing different partners, and you've got we talked about it with the Achieve Health Plan. You've got players coming into the market. They're trying to put together this 5-star meal. They got all the ingredients, and yet everything is not being done in house. What are your thoughts on those newer models? Because obviously everybody's trying to get into healthcare. It's a $3.4 trillion industry. I can't tell you how many calls or emails and LinkedIn messages I get from newer vendors, whether it be TPA, cost containment solutions. What are your thoughts on trying to piece all them together to get them to work and have it effective for your clients?
Well, John, I think I'd answer it like this. Let's say your friends referred you to a fine restaurant. You go in, you're all ready with your mate, and you order your meal. And the waiter goes in the kitchen and picks up the phone and calls Uber Eats and tries to get your appetizer delivered. Meanwhile, they're on the other line. Somebody else is trying to get your entree ordered with Uber Eats. And on the way, somebody gets in a car wreck. Somebody forgets to show up. Somebody overcharges you. They can't deliver what you have. It's the same thing. If you don't have everything done by a trained chef, by an experienced chef, a stable chef, somebody who has been in the market, who understands the dynamics, who understands the details. And this is absolutely a technical and detailed business. You have to have nurses available in-house. When a call comes in and our advocates answer the phone in-house, and they have a question about either how do my benefits work, and our people get on the phone and they said, well, what providers can I use? Well, they might actually get on the phone with them with a provider and talk through the process on a 3-way call. They might steer them through to some of our apps where we can look at quality and at the providers at the same time, walk through that app with them. Well, if you need to be looking at what kind of claim history they have. Are they a high claimant that needs clinical interaction? Have they already been assigned to a case manager? Does that case manager have access to every bit of the claim history? Because if you're not looking at it, if it's not readily available at your fingertips at the moment that they call, you're going to miss the opportunity to be able to better manage that person, better bring them better clinical outcomes, and better manage the pricing for that plan.
Okay, so I got a couple questions here through the live feed, and I know we talked about it earlier, and you go from RBP, you talk about the future after RBP. I've got my client into this RBP product. We've had some success year one. It's been a little bumpy communications. Where do we go after this? What is the next step? How do we optimize the plan and make it better for the experience for the employees, the employer, and as well for us, so we can sleep at night?
I love that question. 3 years ago, we brought on a director of consumer experience. And we did that because of our commitment to the experience that that patient is going to have at every level. So what comes after RBP, and what I hope to be the byproduct of reference-based pricing, is a better educated consumer, a consumer who has got a sense of confidence about their health care, who doesn't feel like they are out of control, but have a partner in the process. And an employer who has a strategy and a plan that will not see the variances that they have seen in the past. It's an ominous process. The second highest expense line item for any employer after salaries is their healthcare plan and their benefits. If we do not bring some solutions in free market to healthcare in America, we'll be on the government plan. All of us.
And I know you had talked about direct contracts earlier. I imagine that's a way, and you've got safe harbors around the country. You've got some in Texas and other states. Is that where we want to migrate them to? Because for me, it's always been much easier, and it's not on the hospital system in New Jersey. It's been a challenge, but we've got the MRI direct contracts or lab facilities. Is that really, I mean, I have to imagine that's where we want to go, is whether it be bundled surgeries and just building out a safe harbor network for the employer. And how do we go about that through that process of RBP? Because most people are gonna come to the table and they don't have direct contracting in their area. How do they go about taking from RBP to direct contracts? Does it become, hey, listen, you now accepted this over the last 12 months. We've had a relationship negotiating. You've accepted our reimbursements. Is it that easy to get them over to that safe harbor position?
Well, it comes with plan design. So you're going to steer them to the safe harbors through your plan design. You're going to strategize a price differential between your preferred facility where there's zero out of pocket versus the rest of the providers. Do I think that the future of RBP is unlimited? It's hard to say, but I think value-based pricing in healthcare is here. I think bundling surgeries is here. We've been bringing all the pieces together on a cash basis for the last 10 years. Many facilities today will give you a better cash price than they will if you use any type of insurance, albeit fully insured or self-funded.
In these markets, is there better markets for RBP in your opinion, working around the country? Is it rural areas, city areas? How does it work? What is your feelings on that for people that are on the call here or on the live and that got some business, whether it be in not just Texas, because obviously we know that's more advanced states, but they're in areas like a New Jersey, a Florida, an Omaha. What have you seen in the different markets?
So up in your neck of the woods, John, in Pennsylvania, we went in with an employer group. Well, this is maybe 4 years ago, somewhere like that. And this was a union shop. Union benefits are traditionally very rich in benefits, lower deductibles, higher level of expectation and a sense of expectancy about the benefits from the membership. And we went in cold, meaning no safe harbor, but we reimbursed a reasonable amount when other players were not in the market. And the hospital within 6 months, we had a direct contract with a local facility, and we worked every single claim, which is what you have to do. If you auto-adjudicating claims is easy. Working the claims is the art form. So that's what you have to do. So it does work in untested markets. You have to have the right employer. So it might be that you need to do the walk, crawl, run approach before you jump in 100% into the deep end of RBP. Now, in this case, in Pennsylvania, it was do or die. So the economics of that employer required that they take these kind of steps. So I think you have to work with that employer, classify their needs, not only their benefit needs or wants, not what the HR people want, but really blending what that economic objective is for that employer. Often benefits are the difference between red and black for an employer. So it does work. You've got to take that into consideration. It can work in rural. I was just with an employer client today, rural Texas, in the middle of truly nowhere. I actually had to go down a dirt road to get to this employer. They've been RBP for 3 years, and they were with a different model than ours until 2 years ago. And the disjointed vendors that were not integrated left the consumer experience at the lowest level and discouraged the employer, but the employer knew its economics required that it take this kind of action. Well, you're going to have the same claims no matter what RBP model you use. You're going to have the same claims whether you're fully insured or you're self-funded. A claim is a claim. They're going to happen. It's all about how you manage them and manage the plan that makes the difference. So changing expectation levels, working with that employer, going to the local facilities in a rural environment. That's probably where my heart really leads is rural healthcare in America. They need our help. And I think this is a way to be able to bring that they certainly cannot afford the accounts receivable that these high deductible plans are leaving. So since most older people are at Medicare or Medicaid or even the reimbursements that they're used to, when they see a percentage above Medicare, that actually gets their attention.
And I hear from the broker standpoint, you hear out in the market and people are talking about you should be as a broker negotiating for your clients, set up direct contracts, doing it yourself. What is your feeling on that? Should a broker be responsible to do that? Should they know how to do it? What are your thoughts on them even trying to do it?
Well, if they've been doing it for 30 years like we've been doing it, then that's a different story. But I've yet to meet a broker that has been able to do that. I think they're highly at risk, and I think the employers are highly at risk. I think the devil's in the details. You better know what the Medicare base rate is between teaching facility and the for-profit in your community. You better know how Medicare works. You better know what repricing on a Medicare level means. You better know the core differential between everything from 100 to 150 to 200. You better know those numbers like the back of your hand. You better know the difference between medical devices and injectables and know how to negotiate them. And you better know HCPCS, J codes, CPT codes, revenue codes, and you better be able to negotiate on each and every one of those. And I will tell you that in absence of that, they should stay away from it. Well, unless they've got really high E&O coverage, of course.
Yeah, I have no interest in doing that. Listen, I got enough on my plate. I don't need to be the hero in every way possible here. But, I think it's something that has grown dramatically, the reference-based pricing market. Now, let's say you're an employer and you're looking to leave one of the BUCA carriers, and I want to go into designing a plan. You talked about crawl, walk, run. Is there a better way to do it, whether it be because I've used the regional networks, things like that? What is your thoughts on a broker moving from where they are? They're with one of the BUCA carriers. Maybe they're even with an independent TPA already. And hey, I want to take that next step, but maybe I don't want to jump in the deep end yet because I'm a little scared, right? As an employer, what should they be? What steps should they be taking outside of just RBP?
Well, even with a network, you can take powerful cost mitigation tools like bundled surgeries or colonoscopies or radiology sources, or we have all of these kind of sources. They're amazing. You can start taking these cost containment elements, and then you can use the plan design to steer the members to utilize those good players in the market, and by lowering their out of pocket. And you have to decide what that value is worth. So it's looking at the big picture. What you want to be able to do, if you want to have your cake and eat it too, the protection of a PPO, and you want to start steering them to outside entities, then you better start doing it with their pocketbook, because it's the only place where they will start listening. So raising the deductible on non-direct contracted entities is where you sort of start. So you go your PPO, great. But if you've got something contracted or if it's bundled, we want to steer you there with little to no out-of-pocket exposure.
Any final thoughts you think you want to add that we didn't cover here? I know it's been a fairly long session, but I think we got a lot of good thoughts and insight on it, because it is a topic. When we did the vote on topics of discussion, this was by far number one. And I'm just happy to have you on with your experience and intelligence from the reference-based pricing market. You tell me, what did we miss? Anything?
I don't think you missed anything, John. I think there are a lot of moving pieces. And I think the key thing is to have it all under one house, have it integrated, be able to deliver. You don't want to take an employer's $3 million a year spend and make it your next E&O liability. Because if you try to negotiate anything directly, the chances of it not being correct and missing components is high. I think that more than anything, we've got to get educated, not only our brokerage community and our TPAs for that matter, but we've got to get the general public educated about what it will take to get a reasonable price for their services. Get the price in advance. And that's what we do.
Well, great. Listen, I appreciate you joining us and coming on. Well, can we have you back again? Because I know you got a lot in that head that I want to get out to everybody.
There's a lot to talk about, John. A lot of secrets to share.
Well, we'll have you back here on the ranch, and we'll have Ed on very soon as well. So listen, I appreciate you joining me, and we look forward to having you back on.
All right, buddy. Thank you, John. I appreciate it.
You got it. Thank you. All right, guys.
Bye now.
That is the show here. If you have any follow-up questions, go ahead and put them in the chat box below, and we'll get back to you. But again, thanks for joining us. We will see you next week, same time, same place, 8 p.m. Eastern, 5 p.m. Pacific. Thanks, guys.